expectations. But the retinal diseases needing anti-VEGF therapy are not only complex, but also sight-threatening. So maintaining the balance between science of anti-VEGF therapy and the art of patient counseling needs thorough professionalism. Hence, this course is intended to deal with all aspects to find the answer to the interesting clinical puzzle and targets comprehensive ophthalmologists rather than retina specialists. So with me, my co-instructors included Dr. Umesh, but he is not able to come. In his place, I would like to invite Dr. Pramod Kumar Sharma to be with us. You can be with us at the podium. Dr. Sangamitra Kanungo, Dr. Krishnendu Nandi, he's I think somewhere here, we called him, and none other than Professor Lalit Verma. He'll be joining, both of them are going to join us soon. So I'll start the session with which one to choose and what matters, money or the approvals. Yeah, put the presentation, please. Myself, Dr. Santosh Kumar Mahapatra. I am working as the Chief Medical Officer at JPM Rotary Eye Hospital, Cuttack, Odisha, and a vitreoretinal surgeon too. It's not moving. So, the anti-VEGF, that is now has become the epitome of retina care. And it has a good number of members to the WISE Council, which includes bevacizumab, ranibizumab, brolucizumab, aflibercept, biosimilars, and newly introduced faricimab. These anti-VEGFs have different structures and different mechanism of action. Like bevacizumab is a full antibody, ranibizumab is monoclonal humanized antibody fragment, aflibercept is a VEGF fusion protein, and brolucizumab is short chain variable fragment. But we are going to at least know what is approved, FDA approved or DCGI approved, and how does money play in our decision making. So the aflibercept is approved for all these indications, which includes neovascular macular degeneration. Dr. Krishnendu, you can join us, please. Neovascular AMD, polypoidal choroidal vasculopathy, macular edema following vein occlusion, diabetic macular edema. In all these, it is approved. And it acts in a dual trap mechanism, and it's a long-lasting VEGF suppressor. But the cost varies between 40 to 50,000. Ranibizumab, it is again effective in diabetic macular edema, AMD, myopic CNVM, being used in ROP, and macular edema due to vein occlusion and others. But the original molecule is not approved for ROP, but biosimilar ranibizumab is. So it is again a VEGF antagonist, but the cost is between 25,000 to 30,000 for the original molecule. I am talking of the original molecule. Then the bevacizumab, which was initially the most used one because of its low cost, but it is not approved for any of the diseases by FDA. But DCGI later on has allowed to be used in Indian population. So the cost here is between 8,000 to 10,000. Brolucizumab, which has been available to us since last 2 years, is approved for both diabetic macular edema as well as neovascular age-related macular degeneration, which was originally the approved indication. And also, we also use it in vein occlusions too. It blocks both VEGF1 and 2 and is a smaller molecule and has a longer duration of action. But the cost is between 35 to 40,000, sometimes more or less. And the biosimilars. Biosimilars has nothing but the molecules which are very similar to the original drug with a smaller modification. And there are many number of biosimilars available in the market, which includes Rajumab from Intas, Ranitidine from Reliance, Bijumab from Cipla, Rani Eyes from Lupin, Osiva from Sun, and upcoming ones like Alkem and IQVIA. Approved indications include AMD, PCV, DME, RVO, ROP, and myopic CNVM. But here are some challenges like administrative challenges and clinical challenges. And the final decision depends upon when we met in real world scenario, which is, I think, the affordability. We have different schemes in central government as well as state, like in Odisha we have BSKY, which covers all the biosimilars as well as the original molecule, but for biosimilar you don't have to struggle, straight away we get approval. Hence it also determines the injectability. And for ROP, we have to think the approval part also, which is ranibizumab is biosimilar is approved, but according to the literature, the larger molecule bevacizumab acts better, but it is not approved. So the confusion continues. Like, we have to consider all these factors: disease severity, affordability, insurance coverage, government schemes, patients, so overall economic as well as systemic conditions, and finally doctor's dilemma to decide which one to inject. Definitely money matters. We have put a chart like this in our hospital so that everybody can see and decide. Sometimes I ask to take a photograph of this and you can come back after taking a decision. So we are still confused between the approvals and the affordability. But we have to take a decision taking all the factors into consideration. My next speakers are going to solve this dilemma by their talks. Thank you very much. I think we can discuss all the questions at the end of the session. I would like to invite my next speaker, Dr. P.K. Sarma, to deliver his talk. Thank you.
Good afternoon, friends. So here, the anti-Vegf is now becoming the standard care of many retinal diseases. We are discussing about the three. So these are neovascular AMD, DME, and retinal vein occlusion associated with the edema. And here, actually, everybody is confused how many injections. So for this, there are studies are there. So we are going one by one. So the regimens are there. There are three types of regimen as followed. One is fixed dose, that means monthly interval or 2 monthly interval. Another is PRN, Prorinata, as and when required. Another is treat and extend. So let us come to the AMD, that is neovascular AMD. So these are the study, CAT, Marina, Anchor, V1, V2. So these are based on the drugs actually. So bevacizumab, so if you are giving the fixed dose that is 4 week or every month or in 8 weeks or 2 months interval. So this the study, it is saying that, so bevacizumab or Avastin per year, you may say it is 12. One study is there. For ranibizumab, it is also similar, it is 12.3. And if you will go for Aflibercept, because it is the longer interval is required, so it is coming around 8 or 7.5. So if you will come again to the PRN, treat and extend, for as and when required, Purinata. So here it is depend upon the compliance of the patient. When the patient will feel that he is symptomatic, he will report to you and you will do the OCT, and depending upon the OCT find, you have to decide, inject or not. So in this, we found that per year it is for bevacizumab, as per the CAT trial, it is 5.9, or that way you can say 6. Pronto, that is for ranibizumab, it is Pronto, Sustain, and Harvard, CAT, they are coming almost 6 or 7. So, so here, in a nutshell, I can say the bevacizumab is around 6 and ranibizumab it is 6.5. So here, the near anti-Vegfs. These are we can say something that faricimab or abicipar, they are the new kit. But brolucizumab also, but little older one. So here, it is every 2 months or 3 months. So Hack and Harrier, it is saying that its number of injection is 6. And Tenea and Luzen, for faricimab, it is 5. And Cedar and Sequoia, it is they are telling the abicipar 2 milligram, it is 6 also. So average dosing for 3 months, it is 6 and faricimab for 5. So what is the real world scenario? So in neovascular AMD, Chima et al. And Kiss et al., they are the as and when required PRN. So it is coming to 6, number of injection per year, 5.6. So almost you can say it is around 6. So let us come to the DME. So in DME, it is now the anti-Vegf is coming to be emerging out as a standard drug for the standard drug for DME care. So here, what is protocol T, Vivid and Vista, and Esomite and Rhine. There are various studies for different drugs. For bevacizumab, the dose is, the frequency or per year injection is 9. Ranibizumab, it is 10, and Aflibercept is 10. Another study is showing that is Vista Vivid. So if it is if it is for 2 years, it should be for 2 years, over 2 years, number of injection is 18. Esomite and Rhine, for faricimab, it is over 10 years, it is 5. So again, if what I told actually, that is fixed dose. If So if we'll go to the PRN, as and when required. So this written study is telling ranibizumab for 2 years, number of injection is, so say it is 11, 10.7. And written treat and extend, it is telling that the number of injection is over 2 years is 12.8. So, what is the here actually, what I am telling that, this one, retain, so treat and extend. As soon as the patient becomes symptomatic, we'll give this one. So the number of injection, even little, with little, patient may come to you little earlier. So the number of injection is here more. So in the nutshell, if we'll go for PRN, the ranibizumab dose is 11, and in PRN, if we will treat and extend, follow treat and extend resign, so it will be 12.8 or 13 over 2 years. So this is the real world scenario. Ratra et al. And Keys et al. So this is per year, that is 2 years. This for ranibizumab it is 7. Per year it is 7, 6.68 means 7. And bevacizumab it is around 6.5, so you can say it to be a 7. But here, if you this is little bit controversy is there. Here you see the same ranibizumab it is 6.687, but if you follow the key settle, it is 3.15. So it is little bit controversial. So this is the in a nutshell. If we'll give Avastin in following the PRN resign, so we'll have 6.5. Ranibizumab number is 5, and aflibercept is little 3.8. So it is 4. But here the thing is that Dr. Santosh described that money is matter. So let comes to about the RVO retinal vein occlusum disorder. So for RVO with CME, SCORE study, MARVEL study, Galileo. So these studies are describing bevacizumab per year, it is 9 injection, ranibizumab 10, and here if we follow 6 months, exactly here it is coming out, so 3.3 plus minus 1, so it will likely to be 4, and ranibizumab exactly the 4. For aflibercept, so the dose is a little bit, it is stronger, longer acting molecule, so it is around 3. So in nutshell, this is the number of injections if we follow the PRN. So bevacizumab 9, ranibizumab 10, aflibercept 4. The real world scenario here is again. So okay. So here the number of injection is different studies, 7 for ranibizumab, another is 4.5 for 5, so and another it is 3.2. So yearly ranibizumab is 5. So thank you so much. And
exhaustively, you have described the number of injections for each indication. I think we can discuss the actual real-world scenario once we complete the presentation by all the speakers. Next, I'm going to invite Dr. Sanghamitra Kanungo. She'll be speaking on when to switch over and how to choose the alternative.
Good evening, all. So what do we choose looking at the features, whether be it OCT pictures or fundus picture? Why do we need to switch? Whether it's because of non-resolution or reactivation, and what do we switch on to? So these are the things I would go through some of my cases to let you know what we can do next. So why there is a need for a switch? There's a beautiful paper on IOVS which tells us that despite favorable clinical results, exudation results in a number of patients after repeated administration over time. Patients suffering from disease recurrences may have developed an acquired resistance to the anti-Vegf therapy, which is known as the tachyphylaxis. So first, let's go case by case. The first is the diabetic macular edema. So this was a 74-year-old male, known diabetic for 34 years, had hypertensive for 30 years. This was his presenting picture in the right eye, 6/12 with macular edema. He took 4 subsequent injections of Accentrix. His vision his vision improved to 6/9, but again returned back to 6/12. Again returned back to 6/9, and he continued with 6/9 over the period of time. So with 4 Accentrix, he was good to go, with all his systemic parameters remaining controlled. Let's look at his left eye. So this was his left eye. He also had a left eye macular edema with a 6/12 vision.
Until that.
He took 6 Avastins in that eye. As he was taking Accentrix, he couldn't afford the same Accentrix in the other eye. So he took 6 Avastins. So this was at the end of Avastin, this was at the end of Avastin. His vision remained 6/12. There was on and off macular edema reducing, but again it was increasing. At that point of time, we shifted him to Accentrix again, and 2 Accentrix, he was good to go with 6/9 of vision. And this persisted for a longer period of time. Now this is a 58-year-old doctor, nephrologist, who presented with 15 years of diabetes, which was well controlled, with a macular edema, but his vision was 6/6. So as the study goes, we observed him, again 6/6, gradually macular edema is increasing. At this point of time, actually, I was a bit jittery, and he was also. Though his vision was 6/6, we injected with Eylea. This was following Eylea. Gradually, his macular edema subsided, and at the last visit, he's still persisting with 6/6, and macular edema is almost resolved. This is his right eye. So the left eye story is like, again, it was 6/6, but again there was macular edema. We observed him. Now the macular edema is increasing. At this point, we injected again with Eylea, as his right eye was doing good with Eylea. His left eye also, we had put him on Eylea. But after 3rd Eylea, at this point, there was no improvement. So we injected Pegenex. After 2 injections of Pegenex, the macular edema subsided, and he continues with a 6/6 vision. Now this was a 55-year-old male with a diabetic and hypertensive. So here he was injected with Avastin. His macular edema was gradually increasing. He was persistent on taking Avastin because he could not afford to. After about 7 injections of Avastin, when we saw the macular edema was quite persistently increasing, we persuaded him to take Ozurdex. And after that, he took Ozurdex, and his macular edema reduced. Now, what the scenario with eyes with cataract having diabetic macular edema? Now, this was one of the patients who had a grade 2 nuclear sclerosis, had a macular edema, underwent cataract surgery. Just a week before, we injected an Ozurdex, and a 2 months, 2 to 3 months follow-up. The second photograph, which tells about 2.5 months follow-up, his macular edema is well controlled, but he has some amount of hard exudate in the macular area. As we know, post-cataract surgery, there are some inflammatory pathways also that act. Therefore, Ozurdex works good in such patients, and we have had a number of cases in this regard. Now, this was another one patient who underwent a cataract surgery, was injected with Ozurdex, and a month probably or 2 months following the cataract surgery, his macular edema has subsided, and there was an improvement in vision. The use of dexamethasone has been well documented, and it appears to be safe and effective procedure for treating patients with concurrent macular edema and cataract. And there was a significant improvement in best corrected visual acuity and reduction in the central macular thickness after the surgery. So this is a patient where he has almost a chronic macular edema, and you can see a round hard exudates covering the macular area. This is a chronic macular edema, as you can see from the OCT. In such cases, I preferably choose to go with Ozurdex because it's a longer acting and works better. All said and done, in diabetics, the glycemic and blood pressure control remains the hallmark of prevention and progression of diabetic macular edema. It is also important to assess the renal status and the anemia, and if the patient is on glitazone or prostaglandin analogs, one should take care of it. Switching to steroids, if non-responding to anti-Vegf, but difficult to maintain a frequent follow-up visit because Ozurdex, the steroids can work for about 3 to 4 months. Pseudophakic patients who have reached a plateau, persistent intraretinal fluid is there, in persistent edema needing cataract surgery, occurrence of systemic vascular events in the near future, associated features such as extensive hard exudates and presence of hyperreflective foci in the OCT or eyes post-vitrectomy. As we know, anti-VEGFs stay for a very short period of time in such patients. Let's move on to the next disease, retinal vein occlusion. This was a 75-year-old male, known hypertensive, and on Travertan has an open-angle glaucoma. Intraocular pressures were well controlled. Best corrected visual acuity was counting fingers, a good amount of cataract also. This was his OCT pictures. After giving anti-VEGF, this is what happened. There was a traction in the macular area. So this patient underwent cataract surgery along with vitrectomy and intravitreal. So all cases are not the same. The next case was a 55-year-old male. He had a BRVO with a hypertensive for 10 years. We were lucky and the patient was lucky with 2 Rajumab. The edema went away and it persisted for a long period of time. But not all are very lucky. Here is a patient after 4 monthly Accentrix injections, the edema did not come down. So one had to switch over to Pegenex. And after that, the edema came down. This was another one patient with inferotemporal BRVO. After 3 Avastin injections, the edema did not come down, so we had to go on with Rajumab. After 2 Rajumab injections, the edema came down. This is a 72-year-old male, known diabetic and hypertensive with a stroke 3 months back. He was not a known glaucoma patient. Intraocular pressure was 16 with CRVO. This was the macular edema, and we went ahead with Ozurdex in the first go. So this was another one patient of CRVO who underwent 6 injections of Accentrix. Still the edema was coming and going. After that, as the patient was from a longer distance, could not come for follow-up, so we put him on Ozurdex next. The next scenario is a choroidal neovascular membrane. This was a 61-year-old female with best corrected visual acuity of 6/60 in the left eye. This was the amount of edema, hemorrhages, submacular hemorrhage, and the CNVM that she had. With 2 Pegenex injection, the hemorrhages had cleared, and she gained back a good vision. A 66-year-old female, known hypertensive. This was a very interesting case with huge PD. I was actually very frightened to go on with the anti-VEGF, but when I injected the anti-VEGF, she responded to 6 Accentrix. Gradually, the PD was coming down. Then again, it recurred back. Then she took 5 Eylea. Again, it was coming down, but again, it came back, and 2 Pegenex. And the last picture, she is 6/18. Again, the edema has come back again. So what more next? Maybe the newer drug, faricimab, we can try. Now, this was a 52-year-old female, known hypertensive. Again, a PD. This was submacular PD with 3 Eylea injections first. The PD gradually decreased, but again it came back. We gave 2 Pegenex injections. Still with that also, increased. Then again, we went back to ILIA. Now we have just given an ILIA recently. So this was again a 63-year-old male. Due to shortage of time, probably I will not cover that. So to conclude, we are very lucky now to have 5 effective anti-VEGF agents and many, many biosimilars. Shifting from one anti-VEGF to the other, if after 3 injections it is not responsive or it is coming back, is a good choice. But remember that variation in individual patient response may lead you to drug choice that may counter results also. You will do your patient a disservice if you think that drug X works best for the patients, and if responsive to anti-VEGF agents is inadequate, corticosteroid is still an option in certain cases. Thank you. You are the best judge, so think wise.
Thank you. As she told, we have 5 effective anti-VEGFs and many, many biosimilars, and that's why the confusion, and that's why we need to choose wisely. I think we are a small group. You can keep your questions ready. Dr. Krishnani Nandi is going to present when we can say enough is enough. That means when should we stop? So all these things are interrelated. So after his talk, I think the clinical part will be over. We can discuss. Please note your questions. You can put us any questions so that we can discuss well. Now over to Dr. Nandi.
Yeah,
Please.
good to see many people attending this session at this point of time. Till now the discussion was how many injections to be given and when to be given and how effective is the injection. Now I am talking little different. I am saying about when to stop, not to give injection. So injection is the mainstay of treatment for a lot of medical retinal disorders like CNVM, PCV, DMO, RVOs, and others, also in some cases of neovascular glaucoma, cyst or macular edema following cataract surgery, which is not responding to the drops. So the most important point is the cost involved in these cases. So these are the trials, landmark trials, which saying there's a burden of injection in 5 years, 12, 24, 7, 12 to 15. These are the number of injection patient need to take in 5 years' time. So very difficult to sustain or continue the injection in real world situation. And there are a lot of unsolved problem. Even though we give injection, we cannot treat the ischemic maculopathy. We cannot treat non-responder, what madam has already shown. And whether to give monthly injection or PRN, that is a big question, because in Indian scenario, monthly injection, many patient doesn't receive monthly injection. They come for PRN, and even we treat the PRN. And residual edema, even if you can see the macula, the fovea is flat, you can see the peripheral edema persisting parafoveal region. Those patients is very difficult to treat, whether to treat those patients or not, very difficult judgment. So when to stop? First, I'm coming to neovascular AMD, the CNVM. So there are a lot of types of scarring in CNVM that happens. These are the scarring pattern where the loss of photoreceptor, and here the well-maintained photoreceptor. This is the important point. The photoreceptor well-maintained, even though patient has received multiple injection, the visual acuity of this patient must be good than the above one. And this is totally scarred, the thin fovea. There is a subretinal hyperreflective material accumulating at the center. So these two patients having very poor vision. So degenerative cyst, you have to identify the differentiation between the cyst and macular edema and the outer retinal tubule. Outer retinal tubule are cyst-like spaces oriented above the scar, and it is about the outer nuclear layer. This is the outer retinal tubule. This is not actually the cystic edema. So this patient is not going to respond well to the anti-VEGF. Here we can stop giving injection. This is another picture of outer retinal tubule. This is the photoreceptor reorientation above the area of the scar. So these you have to differentiate between the cystic macular edema and outer retinal tubule. I'll demonstrate a case. This is a 65-year-old female with a sudden loss of vision in the left eye. This is the lot of outer retinal tubule. There's a subretinal fluid, some area of cystic spaces. So this is a chronic case. Patient was suffering from chronically, and patient didn't turn up about treatment because of the COVID situation at that point of time. But still we offer treatment, and after giving one injection, everything resolved. But you can see there's a huge area of subretinal hyperreflective material is still there. So here we may not inject further. We can stop giving injection to this patient. The case 2 is a RAP lesion. You can see there's a RAP, multiple area of subretinal fluid, and there's a scarring already going on. The patient is late to present to us. Even if the injection with PDT gives a scarring, but vision has improved a little. Case 3, you can see the area of scarring at the center and huge hard exudate surrounding it. And you can see there's a cystoid degeneration along with the central scar. So how much vision the patient will improve after giving injection? So here we may not give injection to this patient. So stop giving injection in a CNVM when you can notice the outer retinal tubule, where you can see the scarring at the foveal area, when you can find the cystoid degeneration rather than cystoid macular edema. Now going to DME and RVO, there are few markers which are available in the literature. Like first is the disorganized retinal inner layer, where you cannot identify the retinal inner layer properly. These cases, even if we give injection, does not do well after giving injection. This is a case demonstration. This is a 54-year-old female. You can see there's edema, but there's a rip at the outer retinal layer. This is not the RP rip. There's a rip at the outer retinal layer. So even the vision is counting finger 2 meter. So even if we give injection, the vision recovery will not be great. You can see the cystoedema is reduced. The rip is still persisting. So you can keep on giving injection, but how long? You have to stop here. And we have to notice the combined lesion. We have to identify the combined lesion. Not only RVO, the patient is also having the arterial occlusion component here. So in case of arterial occlusion component, the patient is not going to do well with injection. You have to treat the basic pathology. So you have to notice our combined occlusion and peripheral non-perfusion and ischemic macula. After giving multiple injections, the macula is ischemic, we cannot treat. Previously also demonstrated if there is a ERM or the vitreomacular traction itself can cause deterioration of edema, non-resolving edema after giving multiple injection. Here you can see there's a ERM formation, which is the cause of this edema is not getting resolved after multiple injection. And another, after giving in CRVO, mostly in CRVO, the patient after receiving multiple injection can result in development of lamellar macular hole with ERM formation. Multiple injection itself can cause ERM formation. So here we have to stop. This is another case demonstration, case 4, diabetic patient. There is a edema here, and see the area. Mostly all other vessels are sclerosed. FFA shows there is a non-perfusion foveal area. Even the patient received PRP laser, the fovea is still ischemic. And another important thing is a hyperreflective crystal deposition at the central of the fovea is another indication where you need to stop giving injection. OCT features helpful when you can see there's a breakdown of the outer retinal layer, and there you have to stop. So the main feature is a drill, the cholesterol crystal deposition, epiretinal external limiting membrane, ellipsoid zone degradation or discontinuity, ERM formation, large cyst. These are the poor prognostic indicator where you have to stop giving injection. And if you say the vision, yes, definitely vision is a criteria. If the vision gain is less than 5 ETDRS later and CST reduction is less than 10% from the baseline after receiving 3 consecutive injection, then either you can shift or you can stop giving injection. Thank you. And any question?
Thank you, Dr. Nandi. Very clearly you have described when to stop. To start the discussion, I have 2-3 questions for you.
Yeah.
How to differentiate between ORT and actual cyst?
Yeah.
That you showed, but for
Yeah.
the audience, can you please exactly tell us?
I'll show my slide again.
Yeah, please show and exactly tell us how to.
Mainly the ORT is actually located at the outer nuclear layer. You can see, I'll use the laser pointer here. You can see this is the ORT. Above the scar, if it can be full cyst, it can be half cyst. If you can see this area, this is the scar formation, and this is the area half circle above the scar. This is at the level of outer nuclear layer. So this is actually the outer retinal tubule. Above that, this is the cyst. This is the outer plexiform layer cyst, and also the few cysts at the outer plexiform layer. So this area, this is a half circle, not full, above the scar due to the photoreceptor reorientation is the outer retinal tubule. These are not cysts, and there's a subretinal fluid here.
That means you have to critically look at the layers of the retina
Yes,
to
you
know
have to
whether it is
look the OCT carefully in order to differentiate these two entities.
and how to differentiate a active scare or
Yeah,
a old scare.
For that we need OCT angiography into the picture. If it is a open loop, that means it is a scar down. Is a closed loop, that means still active fringe. So if it is a open loop, you can stop giving injection. Even if you see suppose this case it is scarred down totally. If you do OCT angiography, you will see lot of open loop configuration. But if it is a closed loop, this is active. But even if structural OCT, if you don't find any cystic leakage, like cyst-like changes, we don't try to inject. Only if there is a structural OCT demonstrate cystic edema, then only we can inject.
So in active scares, it is indication for injection, but
yes,
in old scare,
definitely.
it is not.
But OCT angiography here is definitely very helpful.
And we have seen in few presentations PEDs,
Yeah.
but again we have to decide which PEDs need injection and which are not, like
Nope.
serous versus fibrovascular versus hemorrhagic. Can you throw a
Yeah.
light on that?
Yeah, actually, the PED terminology suddenly changed after the advent of OCTA. Before it was known as PED, pigment epithelial detachment. Now it is termed as sub-RP fluid. Suddenly everything is changed. Because with the advent of OCTA, because we know now the sub-RP fluid is also pathological, but unless until sub-RP fluid associated with subretinal fluid or cystoid fluid, we are not going to touch them. We have to closely follow up. The base marker is the hyperreflective spots. Hyperreflective spots, if you see just above the area of PED, that is an indicator this patient might develop CNVM in future or develop geographical atrophy in future.
Thank you. So with this, I'll have a question for the audience, just to hand raise. What matters more, approval or the money? Can I have the hand raise for approvals, which will, and how many will hand raise for finances? Money matters. Money is a little bit more. I think we all definitely consider money in our subcontinent to be the more important factor. Sir, you can. No, you cannot do that.
If you see, if the all trials is a non-inferiority trial. It's not superiority trial. All trials is being done for diabetic macular edema, for CNVM. These are non-inferiority trial. Means the new drug is equally good as the old drug or the gold standard drug. So we cannot grade as 1, 2, 3, 4. We can say yes, it is as good as the previous drug or approved drug.
So no single molecule can be said to be superior over the other. Every molecule has its own effect. We need to see the exact situation, clinical situation, as well as finances, as we are discussing, to select the injection. All of them are working. They have similar mechanism of action, but any single molecule just cannot be told it is superior. No.
For which reason? For which pathology you are talking about? No, no, no. No, no, no. No, no, that cannot be
Sir,
done.
you cannot give two anti-VEGFs, but you can combine anti-VEGF with steroid. Yes.
For it is being done for diabetic macular edema, steroid is being studied with giving anti-VEGF. The thickness, the macular thickness goes down dramatically, but at the end of the
Sir
day,
has come.
vision outcome is not that great.
Lali sir, please join us in the stage. So now with this discussion, the most important thing for all of us, meeting patient expectation and outcome, how to deal with it. Sir is going to present regarding this most important thing, and when to switch, as we are discussing. Madam can just tell us in brief, apart from her presentation, you can just briefly tell us when to switch over or when to change.
So, first of all, if the patient is given one sort of anti-VEGF, you can continue with the anti-VEGF for 3 consecutive doses. If the patient does not respond or there is return of the fluid back or the lesion back, then you can switch over.
How to decide which one to give?
So, whichever anti-VEGF you are giving, you have choice of 5 anti-VEGF, probably the smaller molecules you can choose. Or in case of diabetic macular edema, if it's not resolving, then you can choose your steroids. If the patient is not glaucomatous or the other contraindications are not there.
Usually for DME, we give Lucentis.
Yeah.
But suppose after 3 injections it is not.
And with good control of systemic parameters, if the.
So which one you suggest?
I would
when
go
you
for
change?
steroids.
Okay. Sir will also help us in deciding that. But
Okay, thank you, Santosh, for this very interesting topic, solve the unsolved. I don't think so. We have all the answers for all these
Not
questions
yet,
you have
sir.
asked.
Not
You
yet,
see,
so we
no. So VEGF, there may be some repetition because I don't know what already has been covered. This gentleman isolated VEGF for the first time, Napoleon Ferreira. He was actually gynecologist. So VEGF is required for normal physiological purposes also, but it's also involved in pathology of all these tumors as well as new vessel formation, and is the main culprit which has been studied. Hence the role of all these anti-VEGFs. Actually, we are all lucky that there's a rain of anti-VEGFs, so many. So I've tried to list it on the left side, the anti-VEGFs which I call first generation, and on the right side is the second generation antibiotics, because these promise more durability, more drying, and maybe cost effectiveness also. And in between you see a huge chunk of biosimilars, and in fact India today has 9 biosimilars which are being marketed. US also has approved biosimilars now. So are these left side dead or what? But believe me, today patient does a lot of homework because he has already been to so many doctors and he has read so much, he is well aware. So a lot of my patients today ask about faricimab, sir, why are you not giving faricimab and all these things. But we have to, be, anti-VEGFs, I think was an accidental this thing by Philip Rosenfield when he, injected Avastin for some other condition and we had dissolution of. So anti-VEGFs have revolutionized the management. And you see in all conferences so many presentations. So Macugen, I think, came, but it went out primarily because the results were similar with PDT. It did not do much good. But in came this Lucentis, Avastin, Eylea, although not approved Avastin, but still Avastin, believe me, 67% of US still gives Avastin because it's the most cost-effective molecule. The purpose of any treatment for any disease wherever this anti-VEGFs are indicated, this treatment should be effective. First, it should be actually safe. You see, I view safety more than effectivity. We should not do any harm because that is what Hippocrates' oath is. Secondly, it should be effective. Thirdly, it should have long-lasting value. Otherwise, masses can't afford this. Unless there is an insurance component to it, masses can't afford it. You see, every 1 month, patient can't come with their relatives, with their family, taking day off, then consultation fee, then OCT, then injection fee. Again, after 4 weeks, again, the same story. So, and this goes on and on. Because primarily, we are not treating the disease. We can't treat CNVM. We just treat the manifestation of that. We treat edema or neoscleration. But this will not go away. This will keep recurring. So, in CNVM, this is where anti-Vegfs have limitations. No doubt, there's no doubt today, all of us are blessed that we have so good injections. But problem is, they work for some time, come back again and again. It's just like, keep injecting, lage raho munna bhai wali baat hai. Keep giving. And believe me, patient starts doubting your integrity sometimes. Patients have told me sometimes, Dr. Saab, every month you call me, har baar. My relatives also started, har mahine lagega, kitna lagega? So that is what pinches this thing. And today, believe me, internal injections have become, honestly speaking, I don't shy away from saying, one of the main sources of income for doctors. And people keep giving injections, whatever they see in the macula, with no disregard to anybody, whether anterior segment surgeon or posterior segment surgeons. You see these 4 indications I have listed from my own library. They have received internal injections. This is left, this right one is a macular pucker. In between you have a macular hole. Here you have a probable diagnosis of PCV. Here this is a scar. But people will keep giving injections. अरे एक लगवा लो कोई बात नहीं, एक तो लगा ही लेते हैं, सब लोग ही लगा देते हैं. So without any logic or scientific reason also sometimes, any macular lesion. So I know of a gentleman, ophthalmologist in Delhi, uske maternal uncle, he gave 2-3 injections. But that patient was suffering from macular hole and then referred for surgery. So that is the drawback of fast, quick earning. So it is Avastin camps, a lot of people hold one vial, they will hold and fit next center, keep transporting vials from here to there. Because money is the main concern. Vial is transported, method of preparation is not standardized. Unlike US, where there is standard aliquoting pharmacies are there. But in this country, there are not multiple pricks. People give, Avastin is kept in refrigerator. So one institution I saw, it was labeled as Avastin refrigerator. Bahar likha hota label, Avastin refrigerator. So their Avastin is kept for weeks and months. So for many, believe me, if you give one injection, patient will have some response. And for many, any regime is okay. Whether 4 weeks, 6 weeks, patient has not come, whether they know the disease, CNVM, whether they know diabetic retinopathy or not, they will keep giving injections. So that is the sad story of anti-Vegfs. Sad part is the last line, therefore I have very honestly written here, more than science, it is the money game. Problem is further compounded because suppose he has given an injection and patient is getting benefit. Believe me, this patient will become a slave. Whatever he says, patient will keep doing. So, and who is gaining is the pharma companies. All these big pharma companies, you see the global sales of anti-Vegf, if you see, it runs into billions and billions of dollars. But Santosh would ask questions, what is the expectation? Believe me, patient today Googles everything. Patient today is restless because most of these are middle-aged or elderly people. They want improvement in vision. They do not want to visit you repeatedly also, by every 4 weeks or 6 weeks. And this gives them stress also. A lot of patients are under severe anxiety, depression because of these reasons, multiple visits. Cost also pinches. People are insured, like in US, more than 80%, 90% market is insurance. In our country, insurance is around 20-25%. Most of the people have to pay from their own pocket. So cost also starts hurting them. So therefore, pharma companies come with freebies, 2+1 scheme, 1+2 scheme. So many schemes are floating around. The only thing a patient keeps succumbing to you every time. You see, I have one lady, 94-year-old lady. His son brings a chair. Son loses the revenue also, and lady comes. She just has vision of finger around 3 meters, one-eyed only. So if she loses slightly, she'll come again. The reason is fear of losing vision. They don't want to become absolutely zero. Because in that age, what do they want? She was a principal actually. They just want to read something. They just want to sign checks. वो डॉक्टर साहब 500 का नोट नहीं पता लगता है 500 का या 100 का है. They just want that kind of. And one patient told me, मैंने कहा कैसा लग रहा है? तो इसे डॉक्टर साहब अपना चेहरा दिखा दो अपने. So we can't, you see, that is the part which, dialogues which we keep hearing. And as I said, there are two types of patients in practice. One is covered by insurance, other are you have to pay from their pocket. For insurance, it does not matter because somebody else is paying. But you see all these schemes which have been floated around, they do not cover. Patient does not want to pay or they may exhaust insurance, especially if the vision is not improving. Believe me, all our patients of anti-Vegf do not improve. So statistically speaking, what I tell patients is 80% chances are you will maintain your vision, 40% chances are you will improve in vision, but 10-20% chances you may not improve at all. Yes. This is the realistic expectation. You see, we are not gods that we give injection, everybody will improve. So I can't pinpoint also. But the earlier the treatment, better the chance. Regular the follow-up, more the chance. Better compliance, more the chance. So therefore, this second generation anti-VEGFs may ultimately rule because the duration of action there is around 8 to 12 to 16 weeks, provided they have initially, given the loading dose. So some patients will come and tell me, Dr. Sahab, wo beta bahar gaya hua bachcha, and once he comes, I'll come. So that you can't, because these diseases are not forgiving that you can come anytime and treat. Some people will wait for permission from CGHS and then get treatment done. Even doctors, they will keep waiting. So patient expectation have risen because of this revolutionary drugs, but realistically, you have to talk to them. So what I do is at the first meeting with any new patient, so you have to spend at least half an hour, 45 minutes. So I'll ask them to wait in the basement. We have a fundus camera, we have an enlarged view. So discuss with them, this is the lesion, this is the retina, normal retina aisa hai, aapka ye lesion hai, and it will take more number of injection. Give them a realistic this thing. If you give them beyond this thing, acha ho jayega, then your practice only will go down because you are not giving them a realistic expectation. Biosimilars came with a very big hope that they will lead to reduction in the cost. But believe me, I have this thing in saying that biosimilars have not lived up to their expectation. The reason being the MRP of biosimilars is 17 to 18,000 rupees. And if you add OT cost, surgeon cost, it comes up to 25, 26,000 bucks, which is not acceptable at all. So I keep arguing with these companies, you reduce the MRP because you give to the doctor at a much lower price. But MRP return is 18,000 rupees. So ultimately cost to the patient is actually more than the eccentrics also. So I've calculated all the yearly cost. Today, cost of innovator, that is eccentrics, is lower than the cost of primarily because MRP return down is 18,000 rupees. So one injection, you give one injection, actually doctor is making huge amount of money in that. So number of injections, as I said, it's a treatment, it's not a one-time treatment. We are not treating the disease, we are treating only the effect of disease. And this we know that more the number of injections, more the response. As I said, the main source of anxiety is fear of going blind because of this injections. Though some patients are afraid also. And depression levels are very high in patients who receive multiple injections. So patients also prioritize their treatment, often sacrificing family, travel, social commitments because they don't want to lose their eyesight. And treatment protocol imposes significant burden. So therefore, we have to inform them of the strategies. How can we please have a sympathetic attitude towards them, explain the entire disease. Like I tell them about diabetes, that is a systemic problem. If you don't control this, I can't keep giving injections. You have to first control your weight, सबसे important. Weight and those 5 things, hemoglobin, glycemia, kidney parameters, lipid levels. So all these things you have to control. And also don't forget sleep apnea and so many other things are there which can lessen this burden. This is my last slide. So we tell them our aim is to stabilize your vision so that you will have reasonably good seeing life all through your life. So this is what we have to tell. We can't expect 6/6 in every patient. So you have to stabilize. As I said, stabilization does occur if you follow a protocol to around 80%. 10 to 20% still continue to deteriorate, not because of your fault, but the disease is such. Therefore, talking to the patient and relatives is very important. Show them photographs, normal response. Some patient may not agree, so you have to say, isko diya tha to response acha hai. But show them data also. Be realistic, don't give them very high hopes. Also tell this is the only treatment. This is the only treatment available on the earth that, you can try. Don't scare them too much also, otherwise they will fall prey to Baba Ramdev and other, protocols where they will have some churn and hope for the best. This also you have to take care. Otherwise, he may not take treatment. And answer all his queries. After you have done your all bug, give him chance. What do you want to know? What do you want? Because if you don't do that, then patient may not agree to your treatment. So that's all I had to share with you.
Thank you, sir, for actually this we wanted to meet the real expectation of the patient. We are discussing about approval versus money, but the money was for the patient. You added one more aspect, money to the doctors.
Yeah.
That was more important, and definitely all the points need to be very critically taken by us. You have to allow the patient to ask questions.
Yes.
That is the most important part of it. Thank you, sir, for being here. Actually, this is a never-ending topic we are going on discussing. Thank you. I'm seeing a good number of audience for this also. I'm happy. Thank you all audience, and we can have a photograph at the end. Sir, please join us for the photograph. Any questions are welcome. Sir is here.
Any questions from anybody else?
Yeah, please. Can you come to the microphone? We are not able to hear.
She's asking central vein occlusion, mild edema, and hemorrhage over the. It all depends on the thickness of OCT, because in BRVO you can, but CRVO normally we don't. Because BRVO is a milder disease. If I tell my patients, अगर आँख में मुझे कुछ होना तो BRVO मैं करवा लूँगा अपनी आँख में, CRVO नहीं करवाएं. Because CRVO, you see, most of the times it's not a forgiving disease. But mild, you have to define. If the thickness is say 280 or 300, so I'd like to treat any CRVO. Yeah, that you are right, because you can't quantify how much hemorrhage is contributing and how much edema is contributing. So you are right, if there is a big hemorrhage on the fovea itself, then you may wait for some time. But you never know how much time will this hemorrhage take to clear also. So I would go if the thickness is, if the OCT thickness is say more than 300, 350, I would like to inject. Because actually you can modulate the course of this disease also by injections. So early injections are important. So, but you posed a challenge. Yeah.
But I think OCT gives a good clue.
Yeah, OCT is important. Yeah, I think then if there's a big chunk of hemorrhage, then you may call the patient after say 3-4 weeks again. Yes, sir.
Madam, one question for you regarding switching. Like a patient has taken 3 injections, has very good response, but the edema recurs maybe around 3 to 6 months later. Do we need to switch, or can we continue with the same molecule?
The edema has come back again?
Yeah, after 3 to 6 months.
You're talking about diabetic macular edema?
Yeah, any or CNVM also. In CNVM also.
In diabetic macular edema, if there is a good response, the edema has come back, you can still go with the same drug.
There's no need to change.
Okay.
If
And
the that means the patient is responding
Responding.
to your treatment.
Right.
Any question? Any more question?
No, I agree with Sanghamitra that if the patient has responded in the past, I will also go ahead with the same. There's no need to change. Unless patient is from very far off distance, and sometimes patient may ask for longer acting because he may not be able to come frequently. Because one of my patient physician, he asked for it also. It's difficult to come because he has to travel from Kashmir to Delhi.
Yeah.
Despite my telling him get the injection done there, he still comes. So you don't want him to come every 4 weeks with taking a flight along with his nurse wife, and so that may add up to the cost. So in such situations, sometimes I may shift also.
That's longer acting injections.
No, in diabetic, I may shift to Ozudrex.
Yes, yes.
Ozudrex does give a response for at least 3.5 months.
If there is no other questions, we'll conclude this session with thanks to the audience, and we'll have a photograph. Thank you. You reached in right time.